Hi, I'm Dr. Mārewa Glover from New Zealand, from the Centre of Research Excellence, Indigenous Sovereignty and Smoking. I'm reporting on our coping and lockdown study and the challenges we encountered surveying across 4 countries. The Coping and Lockdown study was an anonymous online cross-sectional survey of adults 18 and over who at the time of lockdown or prior were using tobacco or nicotine products, alcohol and other drugs. We were interested to learn how they were coping during lockdown and if substance consumption had changed at all. The survey ran from April to July 2020 during the first initial waves of lockdowns in New Zealand, Russia, United States and India. And we have a dedicated copingandlockdown.com website which has information on how to cope during lockdown. It was used during the recruitment in New Zealand and the United States. We ran into some methodological difficulties. First, the questionnaire was designed in New Zealand and then we had to considerably adapt it for each other country, the demographic terms and definitions, for example. It was translated into Russian. Then the Indian Ethics Review Board requested a Tamil and Hindi translation. We were only able to get the Tamil translation done in that time. Due to India's ban on vaping products, the whole section on vaping had to be deleted, and then the whole section on other drug use was also deleted due to it being seen to be too sensitive. We ran into some recruitment difficulties as well. Print media was suspended, online ad space was in high demand, and the staff were all working from home. They wanted us to buy ad packages far in excess of what we needed, so they would have run for too long and the price was excessive. We switched to using our personal social media accounts, which did boost recruitment, but skewed demographics. So in the US, it was mainly people who vaped who did the survey, whereas in India, it was mainly people who smoked who did the survey. There were very different recruitment strategies used in each country. In India, we used an agency to do that for us, and the Russian team ended up having to change to recruiting in hospitals they had access to. A total of 635 people participated, and that exceeded our target, but each country cohort differed vastly in demographics and substance use. This prevented cross-country comparison, and the generalizability of the results will be limited. Lockdown greatly varied by country also. So this graph shows the experience of lockdown, or the measures that were being imposed in India, United States, Russia and New Zealand at the time we were doing our survey, and this is from the COVID-19 Stringency Index, where you can plug in the countries and period to compare this. You can see it's all quite different. In conclusion, we conducted 4 distinct surveys rather than what we had planned. Our data analysis plan then of course had to be revised, and we learned that designing a study under urgency and quickly throwing this together increases the risk of methodological flaws. Our takeaway is that, of course, studying unprecedented disasters is important for identifying how to prevent or mitigate harm. Evidence-based policy decisions cannot be made without evidence. Pandemic preparedness needs to include scoping out potential research questions ahead of possible future events and having investigators, study protocols and materials drafted, preferably ethics pre-approved, and access to rapid response funding at the time events occur. This is my disclosures. The study was funded by the Foundation for a Smoke-Free World, and none of the authors or the centre has any interests in tobacco, any of the products that we were studying. Thank you.